Preface. When Beth first came to my office, she brought her best friend, a nurse, to interpret for her, and clearly also to provide moral support. Beth was quite guarded, almost suspicious, with wide, frightened eyes. She sat with her arms held tightly at her side, gripping a handkerchief. Her head was canted forward, and her shoulders elevated and tense. Her forehead was furrowed, and at 25 she looked closer to 40. She said that she had suffered whiplash in an accident and wasn't getting any better. A friend had referred her to me because of my interest in motor vehicle accident-related injuries. Her insurance company was beginning to question her treatment, since the accident had occurred at speeds of 5 to 10 mph. No damage occurred to either car, and the driver of the other car suffered no injuries. Beth, on the other hand, continued to suffer from terrible neck and shoulder pain, numbness of her right arm, disabling headaches, and grinding of her teeth at night. 6 months of chiropractic treatment and massage therapy brought her only temporary relief from pain, and a nighttime dental splint only slightly helped her morning headaches. Recently, she developed severe pain in her right hip and buttock, with her pain radiating down the back of her leg. X-rays and MRIs failed to show any cause for her spinal or leg pain. Beth had also experienced worsening problems of distractibility and an inability to concentrate. She made frequent errors in her checkbook. Her memory was terrible, and she would frequently misplace things and go somewhere but forget what she had intended to do when she got there. She had recently started to drive again, and would travel to some familiar place in town, and on arriving realized that she could not remember the route she took. She would stumble over words, say the wrong word for what she meant, and then feel stupid. She even had developed a strange stutter whenever stressed. Since the accident, she had become panicky when traveling in a car, especially as a passenger. Her heart would pound for no reason. She had become edgy and irritable and jumped at every loud sound. Thoughts and images of the accident kept popping into her mind, producing distraction and anxiety. Although she finally was able to fall asleep without drugs, she kept waking fully aroused, sometimes with a racing heart, sometimes with dreams of the accident or of being threatened, with no means of escape. She was exhausted by every physical and mental effort, and had dropped out of her master's program in clinical social work. Her extreme sensitivity to almost any stimulus had resulted in her isolation from almost all of her prior social activities. Beth had also developed many neurological symptoms. She felt dizzy when she moved her head too quickly, kept losing her balance and bumping into things, and noticed that her vision blurred whenever she moved her focus from one object to another. Reading caused blurring of vision and a headache. Only an MRI of her brain reassured her that she had no brain disease or damage. As I do with all my motor vehicle accident patients, I asked her in detail about past traumatic life experiences, especially as a child. Similar to many of my patients, she was very open and candid and willing to share with me what must have been a hellish nightmare of childhood. She was supported in this discussion by the confidant and friend who had accompanied her. From the ages of 6 through 12, she was visited several times a week after bedtime by her brother, who was older by 7 years. As if by ritual, he would painfully twist her right arm behind her back as she lay in bed on her stomach, pull down her panties, and rape her. Any sound by her would result in his beating her, or covering her head with a pillow as he abused her. She never told her parents for fear of punishment by her verbally abusive alcoholic father. At age 19, her brother ran away from home and the abuse stopped. During college, memories and panic related to the abuse resurfaced, and she underwent years of counseling, which enabled her to put it all behind her. She obtained her degree, and, prior to the accident, had been pursuing a graduate degree with the goal of becoming a social worker. When I examined Beth, she was quite guarded and defensive. Her dramatic response to strength and sensory perception could be described as exaggerated pain behavior. She manifested giveaway weakness of her right arm and legs, and diminished sensation to pinprick of these extremities and over the entire right side of her head and face. These were all findings that doctors have long considered to be psychological or hysterical. Remarkably, however, her right hand was slightly cooler to touch than the left, and patterns of hair growth revealed subtle but definite thinning over the right half of her scalp. Her neck was quite resistant to passive movement, and bending her neck back immediately caused her to become nauseated. Tightness, tenderness, and trigger points were prominent in her neck, jaw, and shoulder girdle muscles, and raising of her right leg while lying on her back caused pain in her hip and tingling of her right foot. The story of Beth's whiplash experience is a compilation of symptoms seen consistently in thousands of my patients who have suffered injuries in MVAs. These unusual symptoms, encompassing many areas of the body and mind, are so universal and consistent from patient to patient that they either constitute a vast medico-legal conspiracy to defraud the auto insurance industry, or a remarkably consistent and reproducible clinical syndrome. The Whiplash Syndrome has been a source of controversy, confusion, derision, and misunderstanding most of its described existence. It is indeed a syndrome, a diagnosis defined as the aggregate of signs and symptoms associated with any morbid process, and constituting together the picture of the disease. The picture of the disease, in this case, is a diverse constellation of symptoms consisting of pain, neurologic symptoms, cognitive impairment, and emotional complaints. Each specific symptom and group of symptoms is remarkably similar from person to person, suggesting a unique and common cause. The legal defense bar and a substantial number of physicians would assert that this remarkable similarity is related to the phenomenon of secondary gain and the sophisticated coaching of the plaintiff bar. Doubt is cast upon this assertion by the fact that few of these patients seem to recover after settlement of their case, even for substantial sums of money. The green poultice, the healing power of lots of settlement money, is more myth than reality. The real dilemma is assessing the cause and validity of the syndrome. However, is the fact that it frequently occurs in a setting of an insufficient velocity and force of collision to logically cause bodily injury. Another major dilemma is the diffuse and diverse nature of the symptoms. The Whiplash Syndrome seems to affect a great portion of the victim's conscious existence. It impairs the mind, cognitive and attention deficits, the body, severe and widespread pain, vertigo, visual impairment, numbness and tingling, and the spirit, anxiety, insomnia, depression, loss of sense of self. Indeed, one of the most poignant complaints I heard is that the patient has lost who I once was. And years later, although much healing may have taken place, most patients feel permanently and irrevocably changed by their experience. No amount of financial reward cures them of their recurrent episodes of unexplained pain or their altered sense of self. Even relatively minor life conflicts and stresses seem to throw them back into the distraction and confusion, the jitteriness and arousal, and the familiar tightening and spasm of the same groups of neck, shoulder, and low back muscles they know so well. For years I have struggled with the inconsistencies between the physical injuries and the resulting diffuse and disabling symptoms experienced by patients after MVAs. I have searched the scientific literature on whiplash, much of which seeks to explain the injuries to ligaments, discs, muscles, nerves, and brain cells, and axons from a biomechanical standpoint. In courtroom testimony, I have struggled to justify the fact that an individual could have suffered permanent injuries to the brain and spine from a 10 miles per hour rear-end collision, in the face of contrary testimony by accident reconstruction engineers and the powerful weight of common sense. How could one person knocked unconscious for an hour in a football game be left with no measurable cognitive impairment 3 years later, while another, rear-ended at 10 miles per hour, with damage only to the bumper, be effectively cognitively disabled in the same time frame? Why are professional race car and demolition derby drivers not disabled early in their careers from whiplash or brain injury. Certainly, the recent documentation of permanent damage to brain neurons with repetitive blows to the head in football merits consideration in auto accident concussions, but in that case we are talking about dozens, even hundreds of relatively high velocity blows to the head. The first clue, I believe, lies in the meaning of the event during which the injury occurred. One tends not to develop the diverse and disabling symptoms described previously unless the injury occurs in a state of relative helplessness. A second clue lies in the life history of specific traumatic events, especially those experienced in childhood. I have found that the severity of a person's whiplash-related symptoms strongly correlates with his or her cumulative load of traumatic life experiences before the accident occurred. These experiences may be incredibly varied. Another clue lies in the fact that all of the symptoms commonly seen in the Whiplash syndrome may occur with remarkable similarity in other severely traumatic events not associated with physical injury. Examples include natural disasters, exposure to warfare, and social trauma, assault, kidnapping, rape. Symptoms following these traumatic events are generally attributed to post-traumatic stress disorder, PTSD, a purely psychiatric diagnosis. Much of the medical literature tends to ignore the often dramatic physical symptoms, including bowel disorders, myofascial pain, and cognitive impairment that accompany PTSD in a fashion often identical to that experienced in the Whiplash syndrome. Many soldiers returning from multiple tours of duty in the Middle East suffer from a constellation of physical symptoms quite similar to whiplash. We therefore seem to be dealing with a syndrome affecting all aspects of a person's being, including body, brain, and mind. This post-traumatic syndrome is produced by a threat, shock, or injury that occurred in a state of helplessness. The combination of a life threat in a state of helplessness causes all of the sensory and motor experiences to be stored in a person's unconscious body-based procedural memory in a cumulative manner, along with other such life experiences. These past unconscious memories will then tend to recur with any environmental cues to the trauma. Accumulation of traumatic life experiences, especially beginning in childhood, then leads to a condition of increasing vulnerability and decreasing resiliency to further trauma. The somatic and emotional consequences of traumatic stress are generally misunderstood by members of the mainstream medical profession, who refer to the resulting constellation of symptoms as psychosomatic or psychological. Yet, it is clear that this syndrome is common. Research suggests that it is probably well represented in all societies. It may well account for many of the unexplained and poorly managed chronic illnesses that afflict us, and perhaps constitute the major source of visits to the physician's office. Indeed, it may well account for the worldwide epidemic of unexplained back and neck pain that fills the medical literature. The journey that led to this book began when Marcus Couric, one of the physical therapists in the chronic pain treatment program that I directed in the 1990s, referred me to the writings of Peter Levine, psychologist and trauma specialist. Levine developed this model of treatment of traumatized individuals from his observations of animals in the wild, noting that prey animals, although repeatedly threatened, did not seem to develop behaviors similar to traumatized human beings. He noted that when prey animals are no longer able to flee or fight, they enter the freeze or immobility response. During this period of relative suspended animation, all of the chemical neurological events associated with the fight-flight response persist. This produces a high state of activation of the emotional brain, the limbic system, and both sympathetic and parasympathetic parts of the autonomic nervous system. If the prey animal survives, it will arouse and then seem to discharge the fight-flight energy through shaking or trembling in a manner that replicates the physical behavior of the last act of self-defense. This trembling, perspiring, and deep breathing effectively completes the somatic and autonomic activities associated with flight. In doing so, it essentially erases the brain's unconscious memory for what the body tried to do to protect the animal. Without the discharge, the recurrent emergence of these body-based memories triggered by internal or environmental cues to the event produces all of the emotional and physical experiences of trauma, PTSD. Levine notes that humans, although frequently freezing in the face of threat, seldom go through this discharge of retained fight-flight energy. This may be related to our highly developed cognitive brain centers that tend to suppress many instinctual behaviors because of our acquired patterns of acculturation. Dramatic shaking all over is unseemly or hysterical and tends to be suppressed in advanced Western cultures. Abnormal storage of this intense state of arousal and what the body unsuccessfully tried to do to survive is stored in selected brain centers. It will then tend to emerge in the future with any environmental cues to the trauma, even as simple as the whiplash victim getting into a car. This process leads to the syndrome of trauma that he describes in his writings. I realized at the time that the behavior, perceptions, and sensations preceding the freeze response typified the immediate post-accident experience of my whiplash patients, a state of shock, numbing, immobility, and even depersonalization. I realized that the mental state called dissociation very likely represents what humans consciously experience while in the freeze. The time it took the brain to incorporate all of the physical, autonomic, and emotional experiences into unconscious procedural body-based memory explained the significant delay of several days in the onset of pain, cognitive impairment, and emotional symptoms seen in many of my patients. It also explained why many of my patients began to deteriorate weeks and even months after the accident. Finally, it explained why symptoms did not improve and disappear, but rather kept returning after hundreds of therapy treatments, why imaging studies seldom explained the cause of spinal soft tissue pain, and why so few of my patients recovered after their litigation was settled. The so-called green poultice of legal settlement money was basically a myth. Since that moment of enlightenment, I have seen hundreds of victims of MVAs in a new light, taken detailed trauma histories, and began to prescribe treatment programs emphasizing trauma therapy whenever possible. I have taken my ideas to the major auto insurance companies to enlist support in this area of treatment and in research, and have received a predictably negative reception. In this process, I also began to examine and study victims of trauma with a new perspective and started to correlate physical symptoms and syndromes with the burgeoning literature on the physiology of the brain in PTSD. Viewed in this context, I recognized subtle but consistent physical changes in my patients, who have been labeled with the diagnosis of somatization, conversion, hysteria, and secondary gain. The consistency of these findings among patients and their startling correlation with concepts of altered brain autonomic physiology has led me to inescapable conclusion that clinical syndromes previously categorized as malingering, non-physiological, psychosomatic, or functional are based on altered brain physiology secondary to trauma. These in turn may cause subtle but observable changes in the symptomatic body region involved in the trauma. I now realize that the concept of whiplash remains only one small example of the pervasive physical, mental, and emotional devastation of traumatic stress. Although the brain and body is often damaged in auto accidents, the complex but reproducible symptoms of whiplash represent a physiological rewiring within neurons and their connections in the brain more than an injury of the body. The burgeoning literature on brain plasticity in the past few decades has provided powerful support for the concept of life experiences producing structural changes in the brain and its function. Whiplash syndrome in this scenario represents an example of negative neuroplasticity within the brain, not physical damage to the body or to the brain itself. I realize that I am treading on the dangerously thin divide separating the slippery slopes of the brain and the mind. Time may prove that I have slipped a few times, but the research in brain plasticity, I believe, has strongly supported the concept of brain changing the body and experiences of the body changing the brain. As a neurologist, pursuing the topic of a psychiatric illness has presented a dilemma and a challenge. In presenting my evolving theories to my medical colleagues, I have predictably been met with skepticism by physicians that a dramatic physical syndrome with numerous apparently disparate features could have its roots solely in a change in brain and body function produced by an experience. Colleagues in the field of behavioral science have been more receptive, but have still struggled with my contention that the physical manifestations of conversion hysteria have a distinct neurophysiological origin and are not solely expressions of impaired psychological dynamics. Despite the medical community giving increasing lip service to rejecting Cartesian dualism, the functional separation of the mind from the body, current allopathic and even many holistic physicians continue to consider exaggerated emotional states and non-physiological physical symptoms and findings to be derived from psychological causes. Descartes, in fact, was probably not the author of our current concept of mind-body dualism. In his treatise, Meditation 6, of the existence of material things and of the real distinction between the soul and the body of man, he argues that the soul in relationship to the body is very closely united to it, and so, to speak, so intermingled with it that they seem to compose one whole. In addition, in The Passions of the Soul, Descartes attributes a series of states of the mind to physical alterations of the body preceding or accompanying these mental states. However, in Passions, Descartes indeed proposes that anger, joy, and other intense emotional states may be a consequence of somatic or material physical states, but not a cause of them. Page 326. This specific theoretical departure from his contemporary colleagues may well have destined Descartes to be the scapegoat for the evolution of the concept of separation of mind and body in contemporary medicine. As a result, Descartes has been blamed for a concept and language placing emotional and unexplainable somatic complaints in the intangible category of psychological events, and those symptoms and signs that we can measure by our tangible physiological images and measures in the category of physiological diseases. Although we have come to accept that prolonged emotional distress appears to have adverse health effects on the body, our rigid application of the scientific method to our relatively primitive science of medicine has tended to blind us to the subtleties of somatic manifestations of emotional states. In the absence of sophisticated imaging studies and laboratory measures, the early pioneers of medical science relied on keen senses of observation, and the necessity of deriving their diagnosis from the history and physical examination alone. They derive their insights and wisdom from case studies and experience and the cumulative knowledge taught to them by their patients. Many of the insights presented in this book also derive from clinical observations that patients alone can provide, built on a base of knowledge gleaned from the neurophysiological literature on traumatic stress. The result is not an affirmation of the mind-body connection, but of the mind-brain-body continuum. Finally, through this journey, my belief that patient education is a powerful therapeutic tool that has been greatly enhanced, altering the threat of the unknown by informing and educating the patient, changes the body stress response and promotes healing. Many whiplash victims suffer almost as much from the dismissal and invalidation by the medical and insurance industries as they do from the effects of the accident itself. Providing them with a rational and comprehensive explanation for their symptoms is strong medicine. The obvious enlightenment experienced by my patients, the gratitude expressed, and the improved response to therapy resulting from detailed education have inspired and strengthened me in my writing this book. I purposely geared the first edition of this book to general professionals in the fields of rehabilitation, psychotherapy, patient care, and general medical practice in the hope that it would prove to be valuable to their understanding of this challenging group of patients. I provided copious references to show my medical colleagues that I had done my homework. I found, however, that many lay individuals and patients have bought and read the book. Because of its medical complexity, many found it to be formidable reading. In the second and third edition, I have attempted to simplify more complex medical terminology, to add explanatory notes, and to soften the somewhat pedantic prose that often typifies medical articles and textbooks. I have significantly restructured several chapters to resolve some issues of redundancy, and have drastically rewritten the chapter on trauma therapy to include new concepts and ideas that I have developed since the first edition. In the third edition, I have added a chapter on the burgeoning evidence for brain plasticity, a concept giving great hope for the healing of trauma and justify much of my theoretical foundation. I hope that the third edition will provide readers with a more user-friendly route through the complexities of trauma and its brain physiology.